Hello everybody. Today we are going to discuss about the capnography. This is also question which was asked in DRNB critical care exam in June 2022. So the capnography constitutes an important non-invasive technique that can monitor CO2 production, pulmonary perfusion, alveolar ventilation as well as respiratory pattern. The measurement of CO2 in expiratory air directly indicates the changes in the elimination of the CO2 from the lungs. Indirectly indicates the changes in the production of the CO2 at tissue level and the delivery of CO2 to the lung by circulatory system. Capnography works on the principle that CO2 absorbs the infrared radiation. The beam of infrared light pass across the gas sample to fall on the sensor. The presence of CO2 in the gas leads to the reduction in the amount of the light falling on the sensor, which changes the voltage in the circuit. The analysis is rapid and accurate, but with the presence of nitrous oxide in the gas mix changes the infrared absorption via phenomenon of collision broadening. Time versus volume capnograph. Time capnograph. It is most commonly used type of the capnograph. Plot CO2 versus time. The tracing is traditionally divided into inspiratory phase and the three expiratory phase. Phase 0 is the inspiratory phase. Phase 1 is the dead space, which is little or no CO2. Phase 2 is the mixture of alveolar and dead space. Phase 3 is the alveolar plateau with the peak representing the end expiratory CO2. And phase 4 is the at the terminal end of the phase 3 plateau and the sharp rise in PaCO2 sometimes observed and is referred to as phase 4. So this is the diagram which is representing of the waves of the capnograph. The part in the green represents the expiration and the red represents in patient with ETCO generally underestimate PCO2 by 1 to 5 mmHg because of the presence of small amount of alveolar dead space. Factors that increases the alveolar dead space will widen this gradient and increases the slope of the phase 3. During anesthesia, there is increased alveolar dead space caused by reduced cardiac output and decreased perfusion of the lung apices. It is therefore not surprising that studies under anesthesia have found that EtCO2 and the PaCO2 gradient to be slightly elevated at 5 to 10 mmHg. An extreme example of acutely increased alveolar dead space is pulmonary embolism. Thus, abruptly decrease EtCO2 with ventilation held constant and is often indicative of sudden decrease in cardiac output or pulmonary embolism. The other common causes of wide gradient include obstructive lung disease, smoking, advanced age, and the mixed venous CO2 gradient. Malignant hyperthermia have been reported to cause negative PaCO2 and EtCO2 gradient. In such a cases, EtCO2 is clearly not an accurate estimate of PaCO2, and the average alveolar PaCO2 obtained from volume capnograph be more indicative of PaCO2. Now the volume capnograph. What is volume capnograph? Volume capnograph is obtained by plotting expired PCO2 versus exhaled gas volume, usually obtained with spirometer or pneumatochrometer. There is no inspiratory phase in volume capnograph, and the curve is divided into three expiratory phases. So capnography has been used to titrate PEEP setting in as much as narrowing of PaCO2 and EtCO2 gradient suggests reduced alveolar dead space and shunt fraction as a result of alveolar recruitment and improved VQ match. These changes are often subtle and absent on time capnograph and may be detectable only on volume capnography. It has been that incomplete inspiratory valve and the rebreathing during mechanical ventilation may require volume capnography to be detected reliably. The technique may and the time diagnosis of embolism. PaCO2 of 35 to 45 mmHg is of normal value for capnography. However, some experts say 30 to 43 can be considered normal. So this is the example of the volume capnograph. On the single breath CO2. The horizontal axis of the graph represents the expiratory and inspiratory tidal volume and generally divided into three areas. Area 1 is the anatomical dead space. Area 2 is the transitional phase volume. And area 3 is the alveolar volume. And the sum of this value is the tidal volume. Then the second diagram is the graph of percentage of carbon dioxide. The horizontal line drawn at the top of the curve represents the percentage of the CO2 in the arterial blood. And three distinct regions are established. Area X represents the actual CO2 exhaled in the breath. Area Y is the amount of CO2 that is not eliminated because of alveolar dead space. And area Z is the amount of CO2 not eliminated because of anatomical dead space. Now, the clinical application of the capnograph. It is CO2 waveform analysis can give information of leaks in the breathing circuit and airway obstruction. Diagnosis of pulmonary embolism. Estimation of PaCO2 in mechanically ventilated patient and end tidal CO2 can be used to estimate arterial PaCO2 in patient with healthy lung. Indirect measures metabolism and circulation. Provide immediate picture of the patient, condition of ventilation and perfusion warning sign. About hyperventilation, when patient hyperventilate, their CO2 goes down. So hyperventilation can be caused by many factors from anxiety to bronchospasm to pulmonary embolus. Other reason of CO2 may be low is cardiac arrest, decreased cardiac output, hypotension, cold, and severe pulmonary edema. So the graph will look like this. Now the hypoventilation. When patient hypoventilates, their CO2 goes up. Hypoventilation can be caused by altered mental status such as overdose, sedation, intoxication, post-ictal state, post-head trauma or stroke, and by tiring CHF patient. Other reasons CO2 may be high, increased cardiac output with increased breathing, fever, sepsis, pain, severe difficulty breathing, depressed respiration, and chronic hypercapnia. So the graph will goes like this. Now, continuous wave capnography versus calorimetric capnography. In calorimetric capnography, filter attached to ET tube changes color from the purple to yellow when it detects the carbon dioxide. This device has several drawbacks when compared to waveform capnography. It is not continuous and has no waveform, no number, no alarm, is easily contaminated, and is hard to read on the dark and can give false reading. Paramedics should encourage their service to equip them with a continuous waveform capnograph. Now, ETCO2 in asthma, COPD, and CHF. End-tidal CO2 monitoring in non-intubated patient is an excellent way to assess severity of asthma, COPD, and the effectiveness of treatment. Bronchospasm will produce characteristic shark fin waveform as the patient has to struggle to exhale, creating a sloping BC upstroke. The shape is caused by uneven alveolar empty. So this is the shark fin appearance seen commonly in the obstructive airway, suggestive of asthma and COPD. Now changes in the asthma value. Asthma value changes with the severity. With mild asthma, CO2 will drop as the patient hyperventilate to compensate. As asthma worsens, CO2 level will rise to normal. When asthma becomes severe, the patient is tiring and has little air movement. CO2 number will rise to dangerous level. So successful treatment will lessen or eliminate the shark fin appearance and return to EtCO2 to normal. Now about hypoxic drive. Capnography will show hypoxic drive in COPD return. EtCO2 reading will steadily rise and alerting you to cut back on the oxygen before the patient become obtunded. Since it has been estimated that only 5% of COPD have hypoxic drive, monitoring capnography oxygen level in the majority of tachypneic COPDs. Now about cardiac asthma. It has been suggested that in wheezing patient with CHF, the waveform should be upper. This can help assist your clinical judgment when attempting to differentiate between cardiac asthma of CH. About hyperthermia, metabolism is overdrive in the fever which cause EtCO2 to rise. Observing this phenomenon can be life-saving in patients with malignant hyperthermia, which is a rare side effect of RSA. So malignant hyperthermia, the EtCO2 will project like this. So this is the air-lip loose connection between sampling tube and capnography. So the first diagram is showing the rebreathing capnograph of Mapleson D unit, brain circuit, and exhausted CO2 absorption. So this shark fin appearance of capnograph, as we have discussed earlier, seen in bronchospasm, COPD, emphysema. This upward slanting of phase 4, which is a normal variant in the pregnant female during anesthesia. This capnograph is unrecognized exhaustion of CO2 absorber resulted in the substantial rebreathing and rising EtCO2 values. This is the contamination of capnometer resulting sudden elevation of baseline as well as EtCO2 value. This curare cleft when neuromuscular blockage wears off. The patient takes small spontaneous respiration in the paralyzed patient. This resembling curare cleft due to artifact created by surgeon leaning the chest or pushing against the diaphragm during expiration. Now, this capnograph is representative of dilution of expiratory gas by the forward flow of fresh gases during later part of expiration. This is the classical representation of the rebreathing, that is elevation of the base. Now, this is the rebreathing producing the gradual elevation of the baseline and EtCO2 values. Now, occasionally there can be reverse of phase 3 slope seen in the patient with emphysema. Now, this is the endotracheal intubation. Endobronchial intubation may not result in characteristic wave. So, gradual decrease in the end tidal carbon dioxide can occur in the reduced metabolism, that is hypothermia and hyperventilation. Now, the lung transplant, that is a dual capnograph. Slit sampling tube can result in the pictal capnography. Cardiogenic oscillation ripple effect seen during low frequency ventilation. Sample problems such as air and the oxygen dilution during nasal and mass sampling of CO2 in spontaneously breathing patient will look like this. Now the next diagram is showing the expiratory valve malfunction. It can result in prolonged abnormal phase 2 and phase 3. Now again there is increased CO2 due to hyperventilation and hypermetabolic status. So the EtCO2 graph will look like first diagram. Second diagram is representative of inspiratory valve malfunction, predominantly result in abnormal phase 0. Thank you guys.